During this lecture, we'll be getting into the general anatomy of the urinary system. We're keeping any anatomy of the nephron, the smallest subunit of function within the kidney, to a completely separate lecture. So just keep in mind as we go through the urinary system that this topic has a bit of a partner lecture to go along with it. So we'll be looking at the overall anatomy, the arrangement of the kidneys and the ureter and the bladder. We'll also be looking at blood flow through the kidney. I suggest when we're studying this particular section, any opportunity you have to learn things in a sequential order, please take that opportunity because it's going to help you fill in the blanks should you forget something on an exam. So we'll be talking about blood flow through the kidney. We'll be talking about tubular fluid flowing through the nephron as part of our nephron discussion. We'll be talking about drainage from the kidney as it goes down the ureter, into the bladder, and then out the urethra. Any opportunity you have to memorize things in a sequential manner, please take that opportunity. The overall arrangement of the urinary system involves two kidneys and a urinary tract. We have ureters coming from each kidney, draining urine down into a singular midline urinary bladder. Urine is going to be held in that bladder for a period of time and then evacuated from the body through the urethra. When we look at the overall functions, and if we were to ask average folks who had never studied this before what the urinary system does, typically going to talk about the removal of waste products from the bloodstream. They'll use phrases like filters the blood. And while that's true, we are actually going to be looking at another function of the urinary system that's more in line with the overall theme of this class. And that's going to be maintaining homeostasis of blood composition. So yes, we are going to be producing urine, storing and producing urine, until it's time to eliminate it from the body. And in that urine is going to be waste products that we no longer want. Now, keep in mind, waste products can mean things that we have absolutely no use for whatsoever. Or waste products could also mean things that we would use. We just have too much of it right now, so we can let some go into the urine. But the main function we want to focus on is establishing and maintaining blood composition. So picture the overall function here. We filter everything out of the blood, the solutes. We reabsorb back into the blood the amount of solutes needed to maintain normal levels. Anything else, the true waste products and anything that was in excess, spills over into the urine after that. We'll also talk about the urinary system as a means of regulating blood volume, which of course, if you consider the fluid component of blood to be part of blood composition, and that also falls into line with the previous function we just mentioned. We're always going to be varying the volume of fluid produced in the urine depending on how dehydrated or overly hydrated the body happens to be. We'll be using the urinary system to regulate erythrocyte production using the hormone erythropoietin. We mentioned that when we talked about red blood cell production back in an earlier section. Oxygenation goes down. We amp up red blood cell production to increase that oxygen carrying capacity. And we use that, we use erythropoietin as a hormone to drive that production. We'll also talk about excretion of urine, but realize at that point, we are past our physiology discussion. Once we deem a produced fluid as urine, whatever is in that fluid is there to stay. There is no recouping anything out of the urine once we produced it. So we're going to be removing dissolved waste as well as excess substances from the blood with an overall function of filtration. We're going to pass blood through a particular portion of that nephron, and as it goes through the tubular nephron, we effectively filter out the things that we no longer want, that we have in excess, or things that were never of any use to us, a complete byproduct of metabolism. When we look at the kidneys, they will span anywhere from T11 to the L3 vertebral levels, with the right kidney being slightly lower. Remember, we have the liver taking up an awful lot of space in that right upper quadrant. So the right kidney hangs just a little lower than the left one. Around each kidney, we have 3 layers of connective tissue and an opening at the medial aspect of each kidney to allow blood vessels and nerves and the ureter to enter and exit. The ureter is going to be the main tube draining urine from each kidney, extending down into the urinary bladder. This opening is called the hilus. Very similar term to what we had for respiratory, where we had the root of the lung entering and exiting the medial aspect of each lung. When we look at the connective tissue protective layers, each layer is going to have a particular protective function. The first one we're going to look at is the innermost, the renal capsule or the fibrous capsule. For this, we want to make sure we realize how important physical protection is to the kidney. We have an organ that's composed of tubules. I said we'd mention the nephron, and this is what we're getting into now. The nephron is a tubular structure by which we filter and maintain blood composition. The last thing we want in an organ that's composed internally of tubules is for that organ to undergo degrees of compression, torsion, anything that would distort the physical shape of the kidney. Because if we distort the physical shape of the kidney, the tubules inside are going to have an impact. Not much different than if you were to put your foot on a garden hose or kink a garden hose. We want fluid to go through those tubular nephrons as freely as possible. So the first layer we have is our fibrous capsule. This is the outside shape of that kidney and helps maintain the external shape of the kidney. It's going to be the most inner line defense against that compression and torsion. We move outward, and now we have our adipose capsule. It is a layer of fat surrounding the kidney. And when we say insulate, we don't necessarily mean insulate as far as what we refer to as temperature insulation here. It insulates and creates a buffer against physical trauma. It acts as a cushion. So now any trauma coming from the lateral or the rear of the body can compress and distort all of the superficial tissue. And this adipose tissue is going to absorb that distortion and prevent it from being passed through to the kidney structures. The third most external layer with regard to the kidney is going to be the renal fascia. The renal fascia is an anchoring connective tissue that helps maintain the kidney's position inside that lower abdominal cavity. This layer is also important for the adrenal glands that sit directly on top of the kidney. Just like we don't want physical distortion of our kidney, we also don't want physical distortion of any glandular tissue. So having the kidneys anchored in place prevents them from undergoing movement and therefore possible distortion with the tissues around it. We have a number of different terms internally that we have to look at. And to do that, I'm going to recommend we divide this kidney up in 2 different ways. The first is we're going to draw a line right along here. This separates the kidney into a deep and a superficial area regionally. The more superficial portion is our renal cortex. Anything deep to that is our renal medulla. So we first divide the kidney up into a superficial and a deep portion. Next up, we divide the kidney up into its subunits. We want to carve the kidney up, so to speak, almost like we're cutting pieces out of a pie. We want to draw a line straight down two structures that we call the renal columns. The renal columns are going to be more connective tissue-based portions that fall in between the more functional portion of the renal pyramid. Again, I said we'd be referring to nephrons as we go through here. The nephrons, the functional subunits here, we're going to find extending down in to this renal pyramid. So if we draw a line straight down each renal column and take out a section of the kidney, we wind up taking a complete renal pyramid. We also have a deep portion that would be considered medulla, and we have a superficial portion that would be considered cortex. At the tip of each renal pyramid, kind of the point of your pie, so to speak, we have a renal papilla. All the tubular nephrons drain down into that opening of the renal papilla. And at that point, as soon as the fluid that's being filtered out of the blood reaches the renal papilla, we've got urine. We'll be coming back to this diagram once we look at the structure of the neuron and making sure we know how the nephron, applies to this particular kidney. So we drain fluid through the nephron tubule. It exits the renal papilla. Next, we go into our minor calyx. That's going to be the first branch of this draining anatomy. The minor calyx from each of these renal pyramids will converge together to form a major calyx. The major calyx then converges once again to form this large funnel-shaped renal pelvis, collecting all of the urine that was produced by the nephrons in each of these renal pyramids. Urine continues on through the renal pelvis, down the ureter, and eventually is going to be stored in the urinary bladder inferiorly. That's how I recommend you break it up. Superficial versus deep, cortex versus medulla. Look at the anatomy here as we carve out a renal lobe with lines down each renal column, taking a complete renal pyramid. Understand that the renal pyramids are where we see our functional nephrons. I know I misspoke earlier and said neuron, it's nephron. Each nephron drains through the renal papilla, then urine flows into a minor calyx, a major calyx, renal pelvis, down the ureter. In each kidney, there's going to be approximately 8 to 15 renal pyramids, each of which containing nephrons filtering and producing urine. Likewise, we're going to have 8 to 15 minor calyces. Remember, there's a minor calyce for each renal pyramid. They will all converge into 2 to 3 major calyces. These major calyces will then converge into a singular renal pelvis, a large funnel-shaped portion that tapers gradually into the ureter. Now, blood flow is going to be an important topic for the kidney. One of the most basic functions we had mentioned earlier was that the kidney is going to filter blood. We have to understand how blood flows to and through the kidney and around the nephron. So this is also a topic we'll be coming back to once we look at the specific structures of the nephron, because we have to tie that into this anatomy. So first off, we're going to divide this up again to make it easier to remember. We are going to box out these sets of blood vessels. Anything found in that box, we are going to consider nephron blood vessels. These are going to be the blood vessels directly associated with the function of the nephron. So we'll be dealing little with those right now other than looking at their sequence, but we'll be coming back and looking at the details of those once we look at the nephron in more specific detail. So the main artery coming to the nephron, the kidney, is going to be the renal artery. That's going to be branching off the descending aorta in the abdomen. That renal artery now, as it enters the hilum of the kidney, is going to split into segmental arteries. Segmental arteries branching out into segments of the kidney. The segmental artery now will divide into interlobar arteries. These interlobar arteries will run up the renal columns along that same line that we used to define a renal lobe. The interlobar arteries now branch into arcuate arteries. These will run right along the line we had drawn earlier between renal cortex and renal medulla. So they run across the broad end of our renal pyramid. Our interlobar arteries. Now they are going to radiate out perpendicular from our arcuate, extending into the cortex. And now we get into our particular nephron-associated blood vessels, because the interlobar arteries will branch into afferent arterioles. Afferent means to go into. This is the blood vessel that takes blood into the filtration portion of our nephron. That filtration is going to occur at the glomerulus. It is a modified set of capillaries. But it's important to realize here that these capillaries are not used in the same way we used capillaries previously. When we talked about capillaries as part of the circulatory system, we talked about fluid shift. Blood pressure pushing fluid out, osmotic pressure pulling fluid back in. We do not get fluid shift at the glomerulus in the same manner. We get a modified blood pressure called a filtration pressure, pushing fluid and solutes, basically everything except for the formed elements and the plasma proteins, will push fluid and its solutes through slits in the glomerulus and out into the tubular nephron, where now it'll go through the process of being filtered. Anything that doesn't get filtered at the glomerulus and enters the nephron now exits the glomerulus via the efferent arteriole. Now take note that it's still an arteriole. Actions at the glomerulus capillaries had nothing to do with gas exchange. This is still oxygenated blood, and it is still technically taking fluid or blood in the direction away from the heart. If we continue down our efferent arteriole, now we get to a pair of capillaries that surround the nephron itself. Now you see we have two different names here, the peritubular capillaries and the vasa recta. Functionally, we're not going to be differentiating between those very much. They get their names quite a bit based on where they happen to be located in the kidney, cortex versus medulla. Now, because of that location, they will associate themselves with certain parts of the nephron, as you'll see when we discuss that. But for now, I want to focus on what they do. This is a true capillary bed. This is where we'll get fluid exchange and gas exchange with the cells making up the nephron. So we do see behavior at these capillaries much more similar to what we had used the term capillary for before. But additionally, these are the capillaries that will pick up anything that gets reabsorbed back out of the nephron. Remember I said we had a general image now of how this works. We filter things at the glomerulus. That fluid passes into the tubular nephron. Now from there, we can still recoup any number of solutes that we still need to restore normal blood composition. So anything that gets cherry-picked back out of the nephron to be taken back up into the blood gets picked up by one of these two capillaries. These are the capillaries not only of gas exchange for the nephron cells, but they're also the capillaries of reabsorption back from the nephron fluid. Once we leave the peritubular capillaries and the vasa recta, now we're right back into normal vascular anatomy, so to speak. And we will see veins named very similar to its arterial counterpart. We drain into the interlobular vein, which converges to form the arcuate veins, which then converges to form the interlobar veins, the renal veins, and then we get extending into that singular inferior vena cava on its way back to the heart. Each kidney is going to be innervated by a series of nerves, autonomic nerves, called the renal plexus. We will be talking about the kidney as we go, as a means of doing an awful lot of regulation for the blood. We will talk about feedback mechanisms by which the kidney is responsible for maintaining blood volume, therefore having a role in regulating blood pressure and blood composition, as we've already stated that one. So therefore, we have to have a means of innervating the blood vessels extending to that kidney, because that's how we're going to control kidney filtration. Kidney filters blood. We control the rate by limiting how much blood gets to the kidney. Now, I do want to introduce the nephron here, although we're not going to get into it in detail in this particular lecture. We're going to handle that completely separately and make sure we get the fine details. But here is where we would have looked at our vascular component. To put things into perspective and connect the dots, so to speak, on our current anatomy. We have our afferent arteriole bringing blood into our glomerulus. We have our efferent arteriole carrying blood away from the glomerulus. Get my marker to work. There we go. So basically, blood in, blood out, and the difference between the blood in the afferent arteriole and the blood in the efferent arteriole is going to be, we'll lose fluid into our nephron tubule, carrying with it any number of solutes. Glucose, sodium, potassium, magnesium. Anything that's dissolved in the blood would have left the glomerulus with the fluid, with the exception of our formed elements, our cells, and our plasma proteins. Here is the tubular structure that we referred to earlier. As fluid passes along this particular series of tubules, we will see different events happen in each region by which we can reabsorb any number of solutes, we can reabsorb water, we can reabsorb salts, put it back into the blood, because remember we have our capillaries, our peritubular capillary and our vasa recta, surrounding very extensively that nephron tube, picking up anything that we're reabsorbing back out of the nephron tube and into the blood. Finally, here's where our renal papilla would be, as each terminal end of that nephron tubule. Now we produce urine. It goes through our renal papilla. Out here would be our minor calyx. Now, the diagram that we have here in front of you is the way you'll often see nephrons drawn, but I want to make it clear right away that this is not the anatomical orientation. You see this orientation because it's easier to label. In reality, I want you to take this particular structure here and rotate it so that it faces that way. Because this portion of the tubule should actually sit right here, right in the V created by our afferent and our efferent arteriole. Now, that might not sound like much right now, but that is going to be a huge aspect when we talk about regulation. So we zoom in. This is more of an anatomical representation. Here's our capillaries of the glomerulus. Here's our afferent arteriole. Here's our efferent arteriole. And here is that later portion of that nephron tubule sitting right here, created by the V in between our afferent and our efferent arterioles. Once we look at the nephron closer, this triangular group of cells becomes extremely important for regulating nephron actions, blood pressure, and blood composition. We said before that the peritubular capillaries and the vasa recta are given their names based on what region of the kidney we wind up finding them in, but they do wind up associating with nephron structures. We actually have two different types of nephron structures depending on where they sit in the renal pyramid. We have cortical nephrons, which, as you can imagine, sits more so in the cortex. They have a small portion that would extend down into the medulla, but not nearly to the same degree that we see our juxtaglomerular nephrons extend down. They will extend down into the medulla to a much greater extent. For now, we'll look at that as an anatomical difference. But keep in mind that once we look at the nephron, you will see that this portion of the nephron has a very particular function. And because one's going to be quite a bit more sizable than the other, you're going to be able to attribute a certain function to one of these two nephrons that isn't readily apparent just by looking at its structure. So overall, we want to get an impression here today of general urinary system layout, kidneys, structure, ureters, bladder, urethra, we'll get into in just a moment, but also general urine formation. We filter the blood at the glomerulus. We produce a filtrate that extends into the tubular portion of our nephron. That's our tubular fluid. While we're in the tubule, we have the opportunity to reabsorb that which we still want. So if you've got normal blood glucose, that glucose gets filtered at the glomerulus and winds up as part of the tubular fluid in the nephron. Well, you don't want to lose your glucose. You've got normal blood levels of glucose as it is. You don't want to be urinating it out. So you will reabsorb 100% of it back out of the nephron tubule and into the capillaries, the peritubular capillaries and the vasa recta, and get all that glucose back out into the blood where you want it. Now, we also see some tubular secretions where things will wind up in the tubular fluid that didn't get there by way of filtration at the glomerulus. It got secreted through the cells in the opposite direction of everything that's being reabsorbed. We'll look at that again once we look at the structure of the nephron, but this is going to be a major part of our blood pH regulation. If you remember, we talked about the kidney briefly as a regulator of pH back when we did respiratory. Draining urine that we just produced through the actions of the nephron in the renal pyramids of the kidney, out the renal papilla, into the minor calyx, into the major calyx, into the renal pyramid. Now we extend down the ureter, 10 to 12 inches long, towards the bladder. These structures are behind the peritoneal cavity, so they're considered retroperitoneal. The bladder itself is an expandable muscle. If you remember when we looked at it when we did tissues, it's going to be lined with transitional epithelial tissue. It's an organ designed to expand and contract and change its size. It can hold anywhere from 1 to 2 liters of urine, also a retroperitoneal organ. We will see urethral openings at the posterior superior aspect of the bladder, draining urine into the bladder. The trigone is going to be a sensitive band of tissue that extends from the inferior drainage portion of the bladder with both urethral openings, packed with stretch receptors in this trigone. It's the trigone that prevents premature bladder contraction. Basically, the bladder can't contract and void urine from the bladder until it's gotten full enough. So you get an adequate amount of urine in the bladder, you stretch the trigone, and that's going to allow bladder contraction, and therefore the elimination of urine from the bladder that we'll now call micturition. In order to undergo micturition, however, we've got to pass through a series of sphincters and the urethra. Now, at this point, it's worth pointing out that our discussion right now, other than just of the general urethra, is not going to occur. Obviously, we haven't done the reproductive system yet, but obviously you can picture there's a difference between the male and the female urethra. We are going to leave that anatomy for when we do reproductive. We'll look at the differences in the urethra at that point. But for now, the urethra is simply a tube draining the bladder and allowing maturation of urine into the environment. And for each, we will have a pair of sphincters, an internal and an external urethral sphincter, helping control the flow of urine. These two sphincters handle two different phases of urine flow. The trigone, the triangular-shaped stretch receptors at the back of the bladder, controls not only the bladder musculature, but also the internal urethral sphincter. And in that way, the internal urethral sphincter is very much involuntary. It stays clenched. The urinary bladder muscle stays relaxed until the trigone gets stretched enough, and at that point, we relax the internal urethral sphincter and we allow contraction of the bladder musculature. Now urine is going to begin its travel down the urethra until it gets to our external urethral sphincter, made up of our urogenital diaphragm. This is a voluntary sphincter, and it's pressure on the internal aspect of this sphincter that gives us that feeling of urinary urgency, a feeling like you need to micturate. But again, this is under voluntary control, so we can maintain holding the urine until it's at a point where we voluntarily choose to eliminate it. So I'll include the female and male urethra here in diagrams, but we are not going to be responsible for any questions on the differences between the male and the female urethra until we get through reproductive. Obviously, the female urethra is going to be a shorter piece of anatomy. Still have our two sphincters, mind you. And it is going to be purely urinary. Where we get most of the difference and why we're leaving it for reproductive is because we get a lot of overlap with the male urethra with the male reproductive system. We pass the urethra through the prostate gland. We pass it as we go through the urinary diaphragm. We associate it with our bulbourethral glands. And then finally, we get into the urethra and it extends out through the penis, called a spongy urethra. But the function can change based on the reproductive anatomy. So we'll finish that discussion then. We've talked about aging and different systems as we've gone through A&P 1 and 2. And if you've had me for an instructor in A&P 1, you may have heard me kind of downplay aging and its effects on a particular system, because usually we're not really concerned with age, really. What we call age in a lot of systems is really more so neglect. But there are some systems and some organs that do fall prey to time. I would have talked about this during any discussion on the integument system. Sure, some people maintain a youthful skin appearance well into advanced age, but generally speaking, collagen fibers break down over time, having a tendency for the skin to have a less elastic quality, developing more wrinkle structures. Well, the kidney and the urinary system is going to be one of those systems / organs that tend to really change distinctly with age. And there's little that can be done about staving that off. We start to see changes in size and function of the kidneys beginning even at 30. Now, again, think about this in the context of what the kidney and the bladder is expected to be able to do. If we change kidney size, because we see a gradual reduction in kidney size, what is that doing to the tubular nephrons inside the kidney? Remember, we had that renal capsule preventing distortion and distension and compression. If we change kidney size, one of two things has to happen: a reduction in the number of nephrons or a compression of the number of nephrons that we have inside, neither of which is going to do much for our ability to filter blood. We change kidney size, and we will alter blood flow through the kidney. Blood vessels, another tubular structure. If we reduce the number of nephrons or we reduce the effectiveness of the nephrons, obviously we're going to have an impact on the reabsorption and secretion, because we're removing the functional subunits, or at least hindering their ability to do their job. All of that taken into consideration, we have a diminished ability to filter and cleanse the blood. Now we see an impact in blood composition. Now that we've gotten past the kidney, we see a reduction in bladder size. Now remember, the bladder was an organ that was meant to expand and contract. So a reduction in bladder size may mean a decrease in bladder mass, or it may simply mean an inability for the bladder to extend like it used to. Once it could hold 2 liters of fluid, but now it doesn't stretch that much anymore. Now it only holds 1.5 liters. Because of that, you will undergo more frequent urination. And probably out of all of this, the one that comes with the greatest loss of dignity is the loss of control of the urethral sphincters. Now, external sphincter in particular, remember the internal one was involuntary. But you're able to hold less urine, and now as soon as that trigon allows the internal sphincter to relax, the integrity of the external sphincter isn't quite enough to hold the flow of urine, and you'll involuntarily micturate. So as you go through this, realize we haven't really studied the nephron yet. So how I recommend you tackle this subject is you study it as we went through it now, trying to memorize as much of the sequential anatomy as you possibly can. Try and picture the nephron, where it fits in the kidney now, and where it fits into the blood flow topic of the kidney. Go and look at the nephron lecture that we're about to do. And once you get through that, go back and watch the general urinary lecture one more time. Because we really have two topics in one, where we really have to fit one into the other at some point for full understanding. And as always, if you have any questions, please reach out and let me know.